So it's a great pleasure actually to have Paul Morgan talk to us today, and it's what we call a valedictory presentation, which means he's going to give us the benefit of around 25 to 30 years experience. Paul, thank you very much for that, all compacted into a half an hour's talk. So as many of you will know, Paul's actually been an intensive care consultant in Cardiff since 1996, apparently part-time with anaesthesia originally, but 2004 full-time as an intensivist. Interested all the time along there in the area of sepsis. Initially, he's been currently still as tracheostomy lead, but with a particular interest in sepsis and in reducing not just mortality from sepsis, but hopefully better outcomes in terms of morbidity. And he's involved in initiatives such as the Size of Sepsis in Wales. He's also worked for Welsh Government as well. So it's a real pleasure to have you here and to share your experiences. Thanks, Paul.
Okay, thanks very much for that introduction. So, for those of you who don't know me already, my name is Paul Morgan. I'm a consultant intensivist here in Cardiff, and I've been around a long time. Okay, so entitled this talk, How to Survive a Career in Intensive Care and How I Nearly Didn't. Okay, I want to start off by saying this is not a plea for sympathy. This is not a plea for special treatment or critical care. It's just my honest reflections on what I think went well and also what didn't go so well. So a quick bit about me. I'm state school educated, Pontypridd. We were the first year of comprehensive education in Ponty, but got my head down, studied, and was lucky enough to enter the Welsh National School of Medicine in 1980. It changed its name while I was an undergraduate and became the University of Wales College of Medicine sometime in the mid-80s, but I graduated in 1985. And from that, I went to do a fairly traditional house officer post in surgery and medicine, surgery in East Glamorgan Hospital, medicine in Neath General Hospital, both of which are now long gone. And I then did a year of medical SHO in Neath Gen as well. But I'd always sort of wanted to try out anaesthesia, and I went to Swansea and sort of...
Pause back next to your head.
Okay, that's better. That better? Okay. Even as a house officer, sort of fancied the idea of intensive care, and so I thought when the opportunity arose to do 6 months of that in Swansea, I applied and was successful. From Swansea, having done first couple of anaesthetic exams, I went to Bristol, and yes, I was there with Steve Bolson when the brown stuff was hitting the fan, and so it was quite a challenging time, but ultimately I passed my final anaesthetic exams and came back to Cardiff in a post-surgery research post, and then as a post-surgery registrar, which included a period of time as a locum SR. I then went to the West Midlands for my formal senior registrar training in Stoke, Birmingham, and a short appearance in Wolverhampton at the end before taking up my consultant post in August 96. So that was the consultant post in anaesthetics with 3 sessions of intensive care in that. Now, the unit was already starting to grow. It'd been 7 beds when I'd been there as a post-fellowship reg. It became 11 beds, but we were still incorporating paediatric intensive care in that. Obviously, there's been massive changes in how that service has been delivered over the years. We had various high dependency units in medicine and surgery. Gradually, those were sort of subsumed into the footprint one way or another. We also had the closure of the Cardiff Royal Infirmary in '99, so we had more beds coming on site. There's a slow, gradual increase in consultant numbers, but not a huge amount. But what was becoming increasingly apparent at this period of the time was that the ability to remain focused in 2 increasingly separate specialities was becoming more and more difficult. We were already talking about schemes of appraisal and revalidation, although this didn't come for some years later in the upshot of the Shipman inquiry, for example. So something had to give, and eventually, after a period of negotiation, I became a full-time intensivist in August 2004. The service in Cardiff undergone significant reconfigurations, and eventually, despite some quite challenging conversations, should we say, we merged workforces with Llandoch in 2010 and established cross-city working. Of course, it meant we had more beds to take care of, but such is life. In the meantime, lots of other changes have been happening in NHS across the whole of the UK. We went through the process of establishing NHS trusts, GP fund holders. Devolution came along, and NHS services and healthcare became gradually more and more devolved to the point where it's been totally now devolved for several years. That sort of led to the sort of scrapping the GP fund holders in Wales and the creation of local health boards, but the trusts still remain for the hospital services. But eventually sanity ensued, and we ended up with the integrated local health boards, and that's what we have now. And we've been that way actually since October 2009. I say the Cardiff Vale University Local Health Board has been in existence since that time, and yet I still hear people talking about the trust, and it just irritates me. I just wanted to put that in there, just that's a personal annoyance. Okay. So I said, I'm a consultant intensivist. Well, what or who is an intensivist? And often the perception is that we look a bit like this. And we try not to be, but it's just the way sometimes things come across. Okay. In terms of coming up with some sort of definitions from Wikipedia, everybody's favourite all-informed source of knowledge. This is a horribly American definition, unfortunately, because you'll see that it refers to a pulmonologist and anesthesiologist. In itself, it's actually not too bad, the definition. We work in intensive care units. We're a mixture of backgrounds. Certainly in the UK, intensive care is dominated by people from anaesthetic backgrounds like myself. But in Cardiff, we have a mixture of people with anaesthetic backgrounds. We have some respiratory medicine people, and even a couple of nephrologists thrown into a good measure. But it's sort of open to everybody, as long as you do the right training. What is an intensive care unit? Well, it can look a bit like this. So what you see is lots of machines around. We've got a ventilator, we've got lots of infusion pumps, we've got a hemofilter there, we've got probably an ECMO circuit sticking on the left there, I'm guessing, by the looks of what's in that left-hand side of the picture. And somewhere in the middle of all this, on the bed, is the patient. Okay, so you can imagine that the first time somebody comes to an intensive care unit, it's going to be very scary. My first sort of view of an intensive care unit was actually as an undergraduate going to the Cardiff Royal Infirmary when Colin Wise was in his pomp. I mean, the late great departed Colin. I think there was a quote in our finder which described him as a video game in his own lunchtime. So it was a strange place to be. It was really sort of quite, what's going on there? But fundamentally, the place is scary, but we scare because we care. That's what we do. What is intensive care, or is it critical care? Do the terms really matter too much? This is the official NHS definition. So ICUs are specialist hospital wards that provide treatment and monitoring for people who are very ill. Okay, with specially trained healthcare professionals, lots of monitoring equipment, and of course something called critical care units. Slightly odd when the acronym, because of CCU, people tend to think coronary care unit, but slightly. But of course, the one that sort of still abounds a lot in general discussion is ITU, or intensive therapy unit, which is a sort of quite an old-fashioned term that harks back to the origins of intensive care in the UK, which is from in the sort of 50s and 60s in terms of dealing with people with tetanus. First proper ICU in the UK was probably the Leeds tetanus unit. What is critical care? Well, there's specialist hospital wards. We treat people who are seriously ill. So we have people with problems with one or more vital organs, or they can't breathe without support. Specially trained healthcare professionals again, and we talk a lot about the sort of nursing ratios. So we typically have one nurse for every 1 or 2 patients. Of course, that's been stretched quite a lot in the last 18 months because the difficulties that have been faced. But the standard definition is what we call a level 3 patient, which is somebody who's on a ventilator and has more than one organ failure, would have 1 nurse to 1 patient, whereas somebody who's not ventilated might only have, say, 1 organ failure. What we used to call a high dependency patient would be 1 nurse to 2 patients. Okay, so but they can vary in size. Some small DGHs would have as few as 4 beds. I think you probably struggle to find anything that small these days. But there can be absolutely huge 50 beds or more, particularly if you come to go to some of the what you might call the super critical care facilities across the country, such as in Leeds, where they have multiple blocks of ICUs, all sort of together, but staffed very much separately to manage the workload. What do we do? Well, I'm going to say it's quite often felt a lot like this. We've been the hospital janitor. But what is it we actually do? Well, the job we're supposed to do is to save lives. And that's probably a big question as to, are we successful in achieving that aim? We certainly prolong lives. We can support failing organ systems. But I think we're increasingly recognizing that intensive care survival doesn't mean that the quality of life for our surviving patient is going to be what they had before. People who come into intensive care and leave, a lot of them are going to leave in a very damaged condition. And I think we've increasingly recognized that as a problem, and as both physical problems and psychological problems. And that's what starts to play in your mind in terms of, well, should we admit this patient, or what should we do, or how far should we go in treating them? Because we're trying to make some rational decisions about the merits or harm that a particular treatment modality could provide. Okay, and increasingly we talk, we're not so much focused on intensive care survival. We're more interested in what I call survivorship, is actually being able to leave the intensive care unit with something which can become an acceptable quality of life. Difficult one. And of course, sadly, death is inevitable, and we appreciate that it's not always possible to save everybody by admitting to an intensive care unit and putting them on a ventilator, a inotropes and a hemofilter, etc. And again, one of the jobs that an intensivist has to do is make those difficult decisions. We will not infrequently decline the admission of somebody for whom the outcome is not going to be a good one. That's often very clear from the front. Or sometimes we'll admit patients and say, well, we'll give this a go for a proscribed period of time, and if things are going well, we'll carry on, and if things aren't going so well, then actually we may move towards a palliative care situation. When we decline admission, it's not because we're trying to be nasty. We're trying to do our best for the patient and not put them through what could be a fairly traumatic experience for them and their families. Okay, so when we decline admission, I think that then needs to put the focus back on the referring team to say, well, you need to think about how far you want to push this yourselves. Okay, and maybe you should be calling in palliative care. Maybe you should be instituting the DNA CPR orders and having the discussions about end of life care. Okay. I say patients die in intensive care, and about 20% of our patients who actually get through the doors of the ICU will not leave the ICU alive. Of the patients who are coming through the doors of intensive care unit, around 30% that will not leave hospital alive. So we are discharging patients back to general wards, and a significant proportion of them are sadly not going to survive their hospital stay subsequently. So these issues can play quite a lot into how we try and provide the best care for our patients. Okay, if death is inevitable, whenever possible, it is our job to allow and facilitate death with dignity, especially for relief from pain. And we can be very good at that. We got lots of drugs we can do that with, and lots of other things we can do to aid that process. Okay, and of course, also when possible, offer the prospect of organ donation or tissue donation, because again, that can be actually quite beneficial to families of somebody who's actively dying. One of these accusations gets thrown at critical care: it's a very expensive service. Why should we be spending all this money for these awful outcomes? Well, is it really that bad? Okay, the cost of the service clearly had an impact on how governments have invested in healthcare services across the world, and the UK has been in a fairly terrible position for a very long time. So these are critical care bed numbers on an international comparison. We're the blue bar, so we can see actually we've been fairly under-resourced in comparison to a lot of other countries. Okay, and I say particularly if you look at Germany, which is like completely off the scale. We could only dream of that sort of intensive care resource. Is it costly though? Well, again, I think one of the big problems is trying to get some sort of meaningful comparators to what we mean by costly. So this data actually came from the Welsh Government's 2016 delivery plan for the critically ill. Okay, and so this is a plan going back to, I think it was around about 2012 or 13 this was published. And at that time, a typical ward bed would cost you just over £400 a night. A HDU was a level 2 bed, the one nurse to two patient ratio would cost a touch over £850 a night, and a level 3 bed would cost you just a touch under £2,000. Okay, and obviously, those figures will have changed with inflation. Okay. But there's the short term to say that alive or dead hard outcome, in terms of the ICU and the hospital. But if we want to look in terms of what does it actually mean in terms of how those patients are doing afterwards, have we got anything better? So this was studied done way back, published in 2007 by Saxon Ridley, former president of the Intensive Care Society. And I say this has probably got to be the most middle-class email address I've ever seen, waitrose.com. So they did this big investigation using data gathered by Intensive Care National Audit Research Centre, ICNARC for short, and they looked at quality of life, etc., and actually found, in terms of cost per quality added life year, incremental cost, it was just a touch over £7,000. Now, at this time, NICE were approving treatments on the basis if the cost per quality added life year was under £30,000, they would usually approve it. So intensive care is not expensive care. Okay, right. What else is going on? Okay, well, reflecting on my career, we went through a period of significant stagnation in the NHS, which started to change in the late 90s and into the noughties. There was a lot more investment came into healthcare services. Of course, research was leading to better treatments, and of course we were getting better access to the treatments. But at the same time, we were facing the problems with an aging population, and that's continuing. We faced the problem of growing public expectation of what the NHS could provide. And, despite all these changes, what was being seen was a massive ramping up in acute admissions, which is actually outstripping the growth in the service provision. So services actually became more and more stretched despite the investment. And alongside, of course, this also went changes in medical training. I underwent a very old-fashioned traditional training with a 103 or 104 on call, including nights and weekends, etc. Now, of course, we've moved to a situation where medical training is very different. I'm not going to say whether it's better, worse, or much the same. I'm not going to make that call. I personally would not want to be a trainee doctor in the current environment, given the pressures on them. But I do think they get better actual training and education, but maybe lose out on some of the experience that I went through. We learned a lot by experience, and of course, experience means mistakes. What was going on in UHW, in particular in critical care? Well, those who were in this situation became quickly aware that we were in a toxic environment. There was a lot of disharmony. There was, thwarted ambitions. People wanting to progress in certain directions and found that was, maybe being blocked. Certainly, the relationships between the consultants became very, very strained. As in any department, I would imagine there's, a couple of certainly domineering personalities who basically ruled the roost, and that made the rest of us feel as if we were being bullied. And that was a very uncomfortable situation for everybody. There was a lot of friction. Now, despite all this going on, of course, we had managed to recruit a few other consultants, but we simply couldn't retain them because they came in and hung around for a little while and said, yeah, I'm out, and moved to other parts of the world. And then the next thing that happened that, again, there was also going on in parallel. The next thing we had to deal with, of course, was the impact of the global financial crisis, which meant, Westminster government, as it changed its financial strategy and introduced austerity into public services. And part and parcel of this was actually, giving less and less money to the devolved nations. And I think, probably fair play to Welsh government, who were actually honest enough to say, yes, this will impact the NHS. So we sort of knew what was coming in that respect, but of course it was still very challenging to deal with. And I say, those of us, on the front line of NHS services were sort of feeling the pinch, but I'm not convinced that those in the higher echelons of government were necessarily feeling the pinch in quite the same way. What about the health board? What was going on there? Okay, I say we had all this internal wrangling and difficult conversations and what have you. It wasn't clear to those of us that the health board understood the pressures on the directorate. We certainly were dealing with inadequate bed numbers. It was barely a day went by when we were having to, struggle to admit patients. Discharging patients was difficult as well because the hospital was overwhelmed with patients because there's a huge ramp up in acute admissions. Our nursing staff numbers were grossly inadequate. And of course, we also had an inadequate number of doctors. We certainly, consultant numbers were low. We were having to cover gaps in the consultant rota. Training numbers were, just as bad, if not worse. Okay. And there are also questions that are coming around this time because, there's a lot of rumours going around that, were we being treated equitably across the health board? And we weren't sure. We could not be convinced. Okay. And, the question is, well, who actually cared for critical care? Don't know. Welsh government. Okay, so Welsh government, devolution happened, and eventually, as part and parcel of the devolution process, NHS and public health services became gradually totally devolved over a period of several years. Probably one of the first useful things the Welsh government did was in the series of Design for Life reports. So the critical care one was published in 2005, and that set out some standards for different levels of care, so levels 0, 1, 2, and 3, and talking about specialist units on top of that as well. And alongside this was the formation of the critical care networks to try and get people talking to each other. So there were some things starting to happen. Of course, one of the problems is a lot of talk going on, but no money was forthcoming. There's no meaningful investment. And so, we were beginning to feel like, well, that's great. There's a lot of hot air. Where's the investment? Where's the actual improvement to services going to happen? There's a lot of sort of, shuffling of deck chairs on the Titanic. Pensions. I'm going to just mention it very briefly because, again, in terms of pressures that have happened to particularly consultant staff, but it's also going to affect trainees coming through the process now, is the huge changes in pension. We've seen the lifetime allowance curtailed, we've seen the annual allowances curtailed. So that's what's happened to our lifetime allowance over the course of the last several years. We could put in the dizzy heights of £1.8 million back in 2011-12, and that's been eroded, and we're just a fraction over £1 million again now. And for some people, that's having a significant impact on their pension expectations. The annual allowance, probably things are even worse, and the various shenanigans as to how you calculate what annual allowances and what rolls over and what doesn't, and what can be really challenging. Not so much for me because I actually haven't done any private practice since about 2003, but those who are invested in other means to boost their pension have actually found that that investment was probably going to cause them more problems than it was solving. So is it worth it? Well, I have to say overall that, despite these changes, the NHS pension scheme is still pretty damn good. And, in the 95 scheme, which I'm in, you get a lump sum when you retire and an annual pension. The latest schemes came along to give you a better annual pension with slightly different calculations. There's no automatic lump sum, but you can trade in some of your annual pension to take one if you want. Okay. On the bad side, I say there was this, the punitive taxation regimes that came in. So those who thought they were boosting their future pension have actually had that benefit significantly eroded. They will get you any way they can. Okay, and of course, alongside this has been the increase in retirement age. The 95 scheme retirement age is 60, and I'm going at 60. Okay, those who are coming along, later, I'm afraid, may well be facing later and later retirements. I think there's a lot of questions to be asked about, the realism of, somebody being able to work until they're 67, particularly in hard-pressed specialties, on the front line and being hammered. It's not going to happen. Okay, I make no bones about it. I'm a high earner because I'm a consultant, and I shouldn't really complain about my pensions and earnings, and I try not to. I think there's questions about the taxation system of the country, whether it could be fairer or not, and obviously that's been thrown into the public eye recently with the proposed changes in how we fund social care going forward. I'm not sure it's the right one. Okay. I think you should pay tax based on what you earn, however you earn it, and that's a tricky one. Okay, and I'm totally in favour of paying my share and paying it forward for future generations. Invest in your public services now for the future. Okay, one of the other big things that we've done in Cardiff that's had this significant impact on people's working lives is the introduction of resident consultant working in September 2004. This came about because we were facing increasing demands on our time, out of hours, and so this is what one of the sponsors was developed, was to actually provide an ICU consultant in the hospital 24 hours a day, every day. Okay, and I think for the hospital, okay, because this was UHW only, of course, it provided a great service because there was a senior clinician that was always available. Okay, it probably wasn't quite so great to the patients who were actually already in the intensive care unit, because you tended to come in and you'd see lots of patients that you probably didn't need to see, and you'd fiddle with things unnecessarily, and that probably upset quite a lot of colleagues to find that what they decided the day before was changed, often for no apparent good reason. Okay, and it also had an impact on the trainees as well, who were feeling their level of responsibility was being eroded and they were being dumbed down. So that was a challenge. We made a lot of mistakes in introducing a resident consultant service, and it took us quite a few years to realise there was a better way of doing things. Whether we're there or not now, I wouldn't like to say. Okay, but of course, one of the problems is doing shift work is a negative impact on health in all ways. Okay. Okay. Challenges faced. So, we're sort of maybe coming towards the end of the third wave of the current COVID pandemic. But we've had coronavirus around before. There's so much batter around commonly. If we'll give you a common cold, and so what? Okay. But in 2002, along came from China SARS. Okay, severe acute respiratory syndrome, and then later on in 2012 from the Middle East with this Middle East respiratory syndrome, and these were coronaviruses that probably originated in bats and some intermediary, and got into humans and killed quite a lot of people. But overall, they weren't really that much of a problem for the world in general, because they were probably too effective for their own good. And while these things still flare up occasionally, by and large, these two viruses never reached the pandemic potential. Swine flu, however, did reach pandemic potential and gave us a couple of busy years in 09-10, and probably even worse with these second waves in 10-11. But with this, of course, there was a lot of discussions and planning and preparation. It did reveal some problems in that we didn't really have adequate isolation facilities in this hospital, and it's taken till last year to build that thing outside the side of concourse. Maybe we should have done that a long time ago. Okay, but I think the thing is, because of all the preparation work we did and resourcing PPE and training and so on, I think we felt pretty okay about what was out there. Ebola, Ebola was sort of threatened for a little while in the early 10s, because obviously there was big outbreaks in Africa. I mean, in terms of, would you rather swine flu or Ebola? Well, you'd probably pick swine flu. Okay, Ebola is a viral infection with quite a high lethality. But of course, the actual risk of this coming across to the UK and infecting somebody was probably a lot lower than was being, played in the media, for instance. Okay, but again, we went through a lot of preparation and planning. We still identified this issue of a lack of isolation facilities, etc. And certainly it was felt that yes, we could admit somebody to our intensive care unit in the one cubicle we had that was probably fit for purpose. But it would have been pretty difficult. And of course, anytime there was a rumour that there's an Ebola patient in Cardiff, of course, never transpired to be so. But the panic assumed, this and to be fair, it was probably not a nice thought to think you might have to deal with one of these patients. Let's say, you're not going to get it. What happened then? Well, gradually there was a bit of change that happened. And there were a lot of changes at the leadership within the directorate. There were changes in leadership across the health board. Again, at Welsh Government level, there's some changes. And eventually, we ended up having an external review of critical care services, which has made a lot of recommendations, and those recommendations are gradually being implemented. Okay, so I think we've seen some glimmers of hope in terms of how we can move forward from what was a fairly torrid time. December 2019, the first mutterings of something happening over in China with this new type of pneumonia began to reach the international media, but there wasn't a lot of information coming out. There was, was this some sort of virus? We didn't really know very much, and it really wasn't until the late 2019 information came out about what was actually going on and the size of the problem they were dealing with was. And again, I think a lot of said, well, okay, that's over in China. They've dealt with SARS before. They know how to close this all down. But of course, international travel, of course, had increased massively over this time. And suddenly, cases are starting to pop up in other parts of the world. Okay, and information really sort of started coming out of China in January 2020. And I think, whatever conspiracy theories you may subscribe to, I think it's probably true that the Chinese government didn't want a lot of this information leaking out. By February, of course, we were starting to see the first cases happening across Europe, in Italy particularly badly, and also other European countries, and then gradually cases started to pop up in the UK, and we knew by now that we were dealing with this little so-and-so. This is, of course, the SARS-CoV-2 virus. Okay, March comes along, and cases were starting to spread in our way, and it was pretty clear that something bad was going to happen. And indeed, I'm sure a lot of you can remember when the Prime Minister, having sort of spouted a lot of hot air about what the real magnitude of the threat was in the early parts of March, then when he got himself infected and ended up in intensive care at St Thomas's and almost died. Where was I in all this? Okay. I think it's probably fair to say I went missing in action. I had a lot of issues going on in my family. My father had been diagnosed with bowel cancer and had to undergo surgery. Luckily, that went really well. I was at the Royal Gwent Hospital, thank you to them. My daughter was expecting our second grandchild. He'd been diagnosed with gastroschisis at 11 weeks. She had a very difficult pregnancy. Also, March 13th, she underwent emergency section, and my grandson went and had his gastroschisis repaired that same day. Huge thanks to the team involved. My son's got Crohn's disease, so he's immunosuppressed. I was beginning to get worried for the risk, not only myself being infected, because I've got arthritis and I was on NSAIDs, and of course we were starting to get these rumours about, NSAIDs and COVID, that's a really bad combination. I'm overweight and I'm unfit. So I was worried about, not just myself getting it, but also passing on to vulnerable members of my family. I began having panic attacks. Sitting through meetings where we were talking about the preparations for this, oncoming awful situation that we were going to face. I was really struggling, but I was trying to reassure myself that actually, yeah, we're going to be protected. We've got access to good PPE. We've got the best. There'd already been plans put aside to make sure these patients were going to be intubated by somebody else, so we weren't putting ourselves in that risk, or were we? Okay. So we're sort of, I can push through. I've only got so long to go till I retire. We'll be fine. Okay, and then of course came the moment where I was exposed. There was a patient up on T4 at the time who was in there for a neurosurgical diagnosis who developed respiratory failure, and we were sort of thinking, well, actually this is all due to an aspiration pneumonia. No worry, but of course we were just beginning to think, well, probably we should test these patients for COVID, and late that evening, I was phoned up by a colleague who said, actually, this patient tested positive. And that was the end of me. Couldn't sleep, couldn't function. I felt totally and utterly helpless. Racked with guilt for what my colleagues were going to face. And over the coming weeks, I began to wonder, would I ever work again? And of course, March the 23rd was the day that the UK went into national lockdown. So it was a very strange world to be in at that time. However, after a bit of time off, about 2 months overall initially, and lots of helpful discussions with our clinical psychologist, I began to feel better. I began a phased return to work, which was initially non-clinical, got involved in some bits and pieces that were going on, and eventually the opportunity came for me to go and work in the post-anaesthetic care unit, which is our elective surgical unit for high-risk elective surgical patients. Of course, they'd had to largely stop work during the first part of the pandemic because of the risks involved. But gradually there was a plan made to reopen the PACU. It needed consultant support, and that was me. And for me, that was life-saving. So worked in there for a while, and of course I began to think, well, okay, I'm feeling better now, and you know, things went on. I think, well, you know, what do I want to do? Should I go back to the unit? Should I not? I'm not sure it would have been sensible. And eventually, after quite a lot of conversation, I decided I'm not going back. And so I'm going to be finishing my clinical career working in PACU, as part of the protected elective surgical unit. Of course, I've had a lot of time to reflect on what happened. And it certainly became clear to me that, although I hadn't realised it at the time, probably I'd been burning out for probably a few years beforehand. And I think one of the biggest challenges for any healthcare professional to realise, actually, I'm going through this. I need to recognise that this is my problem, okay? And it's not going to affect just me, but it's also going to affect my colleagues and my patients. And at some point, you need to understand where you are on this spectrum and maybe do things differently. I think one of the most useful phrases that came out as the pandemic hit was, it's okay to feel not okay. Okay, and again, recognizing that as being the position I was in was quite helpful to me. We need to understand that if we're not well, whether that's physically or mentally, that's a problem. Not just for yourself, but also the work you're trying to do, because you're not going to give the quality of service that your patients deserve if you're struggling. I say, in retrospect, I was a ticking time bomb. Looking back, I've been burning out probably for 2-3 years at least before this. Okay, but it was these other aspects of work that kept me going. The sepsis work, the tracheostomy work, etc. And again, it was one of those things in terms of saying, well, I've only got a limited time to go. I can plough through this, okay? But not realising that, of course, there's building up the moral distress and moral injury, and that that being shared with colleagues, we found it struggling. So, what have I learned? I thought I was resilient, and a lot of emphasis on resilience training in the NHS in the past few years, but things accumulate to the point where it just stopped one thing. That straw broke the camel's back. Okay. I've recognised that stress and burnout have cumulative effects on our health, okay, and that no one is immune to these mental health problems. I do worry for my colleagues in intensive care. I think there's going to be a lot of people needing a lot of time off coming up to try and process what they've been through and actually to recover themselves. Okay, I think we need to understand that a little kindness does go a long way. What about the future? Well, I still think critical care is a great career. It opens up lots of avenues. It opens up lots of opportunities to do things other than that frontline job, which is obviously still vitally important. Okay, but you've got to be aware of your own limitations and also understand what's going on with others around you. Okay, so we all want to do a good job, but we also get frustrated by things we have no control over, and that's very, very difficult to say, and that's why we get this problem of moral distress, moral injury. There's been an increasing awareness of the problems of stress and burnout, got magnified by the pandemic, okay? And I think people need to not be afraid to admit that they need help, okay? In the meantime, health ministers have come and gone in my career, chief executives have come and gone, some good, some bad, okay? Medical directors have come and gone, we've outlived them all, okay? And your chairs of the health board as well come and gone. But ultimately,
Well, thank you very much, Paul.
Thank
That
you.
was a very personal sharing, but I think a really important thing to
Yeah.
share. I take away that phrase, a little kindness goes a long way, because actually caring for each other makes the whole stress quite a bit less. It's when you don't feel that you're loved that it makes it much harder, isn't it?
Yeah, and I think that's a two-way street. I think there's probably been lots of occasions where, as consultants in intensive care, we've not been kind to colleagues. And, if you're kind to colleagues, you get the kindness back.
Yeah.
Being nasty to people gets you nowhere, just causes more and more distress.
And we all feel that stress, so
Yeah.
you want to be shout at somebody.
Yeah.
It's a bit like my father was a surgeon, and the question was, why do surgeons shout? And the usual answer is that they're stressed. Not because they're being nasty to people, but because they're feeling stressed. And then it spreads it out. So a little kindness goes a long way. So we've run out of time for questions, but that's probably a good thing. We don't always have questions at the end of the valedictory. But I just want to thank you so much for what you've given to the NHS, first of all, because when you look back at the huge amount that you've already contributed, what you've given to us today to think about. This is not an easy profession, but it's a very rewarding one at times. And what you've given to all your colleagues over this period of time. So thank you very much.
Thank you very much.